circumstances. ECMO is a fairly unphysiological support meant for truly situations where there are no pulses or there's no rhythm. It's certainly not a support that I recommend for supported PCR. I may on occasions recommend it for catastrophic shocks.
Okay. His pockets were constrained, sir.
Yeah.
That is the real reason.
So you may not have an impeller that time.
Thank you very
No,
much.
Impala was available, but he could not afford the same.
Sure.
Thank you.
Big hand. That's Dr. Hanny Ragy, can we have your presentation, sir? Sorry.
Thank you very much. I realize we're probably running late, so I'm going to rush. I'm going to present a very simple case. Maybe I've made a crime in it, so I'll be interested in knowing if I have or not. And yes, I probably would have done it differently. It's just a simple case. Again, it's a case which I always, on going to important meetings, I have this habit of choosing one of my very last cases. So this is a case which was done just a few weeks ago. It's a 73-year-old man. He's insulin-dependent diabetic. He has a very sedentary lifestyle. He's a very pious man, just spends his time praying at home. He had recent worsening of angina, near class 4, when he bends to pray, when he goes to the bathroom. Somebody sent him for a CTA. I wouldn't have, but anyway, it revealed a heavily calcified ostial LAD stenosis extending into his left main and a subtotal calcific mid-LAD and diffuse disease of an OM1 of a non-dominant circumflex. You're going to see them now with a patent RCA, a large RCA. The case was discussed with the patient and his family based on the CT findings. The patient refused the bypass and was sent to meet the cardiac surgeon again and refused the bypass again after all explanations of its superiority in long-term outcomes over PCI. And then he was sent to me for an elective transradial PCI. That's his RCA, which looks fine, and a big one. That is his LAD with a diagnostic 5 French cath. You can see the ostial LAD, that's his left system, the mid LAD calcific lesion. Please look at his circumflex, okay? Its ostium seems normal, and it has an OM which shows diffuse disease in the mid part with some critical focal lesions. His diagonal is fine. These are just diagnostic runs. And it's a true ostial, and as Mamas just said, don't try to nail it, so you're gonna stent into the left main. So, you know, it was easy, just one wire, pre-dilatation of the mid-LAD, and stented the mid-LAD with a right size stent, and then, you know, wired the, because now we're gonna go into the left main, so a second wire into the circumflex, pre-dilatation of the left main ostium, 4 millimeter by 18 stent, post-dilatation of the stent. Rewiring, of course, of the circumflex through the proper strut. Pot using 5 millimeter balloon and then we even did a post-dilatation of 4.5 of the mid part of the stent, and again a pot with 5 millimeter in the proximal in the left main, and that was his final result. Now was the million-dollar question. As you can see, I mean, you know, there's no, no effort was denied to optimize the main stem, which is the LAD and the left main stent outcome. However, and now we have TIMI3 flow in the circumflex with some pinching of the ostium, and this was the decision. Should we do something to the obtuse marginal to optimize the result? Because we have been told now over and over that when you're lazy here, those patients might come again with restenosis of that ostium or even thrombus. I'm one of the operators who feel that if it is such a non-dominant obtuse marginal, working in it might be much ado about nothing. And I'm super careful about not distorting the left main stent. This is an unprotected left main stent. So I took a decision, look at this. I mean, it is pinched, but the flow is normal. And if you work there, there's a lot of work you're gonna do in the mid-OM. So I decided just to leave it. The patient is doing okay at the moment, but I will pose a question. So PCI of the left circumflex may reduce future events, may reduce restenosis of the circumflex ostium. It will disturb the left main stent integrity and will create a big job of treating a diffusely diseased OM. We'll change a simple crossover strategy to bifurcation PCI, and we know that simpler is better. It will use more contrast and more X-ray. Provisional only if angina on table, which was not the case in this case, if reduced TIMI flow on table, which was not the case in this case, or threatened closure. So follow up with intensive LDL lowering. We now bring the patient's LDL to incredible numbers, to below 40 quite commonly, and only treat a future angina as likely. Now, why do I think I probably made a mistake in this case? Because of this paper. This paper was published just on the 30th of June 2022, and it talks about side branch late thrombosis after left main coronary artery crossover stenting. And it shows something I want to show you. Look at this video of an OCT in exactly the same situation. The video will come. It's I took it from online, and they did get thrombus, and the ostium did thrombose, and Mamas just showed us, and this is the thrombus on OCT. So I'm going to follow this patient up, and I'm going to find out if I committed a crime or not. And would I have done it differently? Maybe. And I'm really interested to know the thoughts of the experts on the panel and in the room. Your thoughts. Thank you.
Open for discussion.
Ashok will be final because we listen to his comments. So finally,
you go first.
So
The issue here is, would you treat this side branch as an important side branch or not? So going by the criteria, your side branch is certainly a long one, more than 70 millimeters. It's reasonable, 2.5, 2.75. The ostium may be 3. Thirdly, this is a supply more than 10% myocardium. So I would treat it, as simple as that. Now, stents, studies have clearly shown, even EBC recommends that major side branch, especially the circumflex, we're not going to treat the vessel as well open the struts. So it is not a question of having no struts on IVUS or OCT lying across the ostium. The entire question is of circularity. Circularity promotes linear flow, laminar flow. Though there is no clear-cut data to show that ellipticity versus circularity, what is better. That's why EBC recommends that for left main distal bifurcations, always have a kissing balloon to approximate the stent. That is the basic thing. So to approximate the stent, you may not achieve circularity all the time, but approximation is more important than having malapose struts. So here, I would certainly open the struts with a nominal balloon. Pressure is totally your at what pressures you want to go, and I would play on the front foot. And if there's a dissection or there, and even if suppose there's a 10% residual, I will leave it alone. The good flow.
Thank you very much for this.
Yes.
And I see your point very well, and it is a common point of view. But to answer that, the master of crossover on the left main, which is Dr. Park from Seoul, will actually not open the struts routinely over a circumflex if it's a small non-dominant one, because he believes that any form of distortion of the left main stent, it's much ado about nothing. It's like the main highway between and a small side branch. So Dr. Park, if he was here, and I'm sure he would have actually said that in a crossover on a non-dominant circumflex with TIMI3 flow, patient's happy on the table, you can deal with the restenosis if it happens, but don't open the struts. So this is just the other point of view. And
Hanny, I'm just going to support you in what you say. Truly, this is, this actually got too projected after the EBC main, because it just was a hypothesis which they utilized in every patient. These are anecdotes, by the way, a thrombus forming. Ronnie has got some great images of tissue bridges which have led to unstable angina. But then we can also show you pictures where somebody tried to cross into the side branch and actually went under the struts of the left main and crumpled up the stent. And of course, it's been time consuming, contrast consuming, and also consuming. And you can create problems. This actually needs a randomized trial, and that should be the future randomized trial. Kissing, final kissing in left main to open up the struts. Has it any role whatsoever? By the way, Park's 1,000 patient data clearly told us it has no role. In fact, there's a 150 patient study Swami and colleagues have done from India, crossover stenting. The side branch circumflex has not been dilated as long as it wasn't pinched. Follow-up up to 1 year is being published. And truly, we need to start a randomized trial on this. I think it's superfluous to actually, if the circumflex is open and wide, it's superfluous to remove the struts from the front of it.
Thank you.
So it's also the philosophy, because the European philosophy is clearly to open the struts, whereas the non-Europeans, they possibly want to just leave it alone. So that the philosophy also matters a lot here.
It's a philosophy.
Yeah. Thank you very much, Hanny. You really generated so much of discussion, and I would like to thank everybody who participated in this session, all the experts as well as the discussants. Thank you very much. Give a big hand to all of them.